Yes.
Ah, okay. So lung ultrasound, I'll try to be brief. So basically, lung up until now was considered as a major hindrance for ultrasound because ultrasound doesn't travel well through the gas, does not travel well through the bones. And in fact, lung ultrasound is reinvented science because what happens is that there is air within the lung and air, tissue, fluid, blood in the lungs that all creates artifacts. And those artifacts are now interpreted and they are considered as cornerstone in interpretation of lung ultrasound. So it is something like this, this is inside the sea, these white rays which are coming from the surface of the air fluid interface, they are actually nothing there, but this is the way the rays are seen. And then there we have to find out a mermaid inside. This is Professor Lichtenstein. I had an opportunity to visit hospital Emeraude Pare and spend one day with him and to get my doubts cleared and learn from him. Professor Lichtenstein is considered as father of lung ultrasound. He was the first one to question that this traditional wisdom which was taught in Harrison, that don't use ultrasound for lung. And then in a series of publications, he described all the signs of lung ultrasound. So basically, it has advantages. It is a fast, real-time assessment of lung, no radiation, multiple examination possible, high sensitivity and specificity. It is better than X-ray for many conditions. It is helpful for doing UHG-guided procedure, increasingly used in NICU. And we know side effects of radiation, and a lot of babies are getting high radiation exposure. Less than 1 kg babies had a very, very high dose of radiation exposure. The beauty of lung ultrasound is that you don't need to know anatomy very well, because the problem with some of guys comes is that they have to understand the anatomy very well before. But in lung ultrasound, you don't need to understand anatomy because it is interpretation of artifacts and not interpretation of anatomy which you are seeing. So that way it is easier to master. Studies have shown that 1 or 2 days of training is also many times sufficient. Now, normal lung, basically, when you look at normal lung, when you're getting an image, you need to understand where you need to focus. Now, when you put a ultrasound probe, this is a upper rib, this is a lower rib. Below the rib, there is, sorry, I'll put a pointer. So this is the upper rib, this is lower rib, this is the pleura, and this is the lung. So when you're doing lung ultrasonography, upper rib is going to cast a shadow, so don't look there. Lower rib is going to cast a shadow, don't look there. And you have to look between these two, look in this particular area, which is going to be your lung. Okay. Now, all the signs in the lung, they arise from pleura, and A line and B lines are the artifacts. Now, you need to get used to A line, B line in lung ultrasound because they are the most important artifacts that we have to interpret. Now, first thing is a pleural line. Look for the pleural line. So just below the ribs or about half a centimeter below skin surface, there is a first bright horizontal line. And that is the most bright structure in the lung ultrasound. And so that is a pleural line. And so if you see, it gives a bat-like structure. So the upper rib is seen like this. The lower rib is seen like this bright structure. And just below that, this is the pleura actually. This is the first pleura. This is the pleura. And this is soft tissue. So upper rib, lower rib, and pleura. This gives a bat wing appearance. So this is described as a bat sign. And again, there are many signs. Many of them, they have just a naming importance. But this is look for bat sign. So in lung ultrasound, if you see, you will be able to see lung slide. It's not working. Okay, 1 second. Okay, so this is not sliding, but the lung ultrasound slides like this, and you will be able to see the sliding of parietal pleura versus visceral pleura. So when the baby is breathing, you will see the sliding happening at this junction. Now, which are the A lines? So first one is bat sign, lung slide or pleural line. Then after that, what you see are many horizontal lines below the pleural line. So this is A line, that is called as A line. So these are the bright horizontal parallel lines equidistant from pleura, and they indicate presence of air. So normally present throughout the lung field. So whenever there is air within the lung or air underneath, so even if it is pneumothorax, you will see. But what it indicates is that presence of air. So pleural line will be there, and after that at equidistance, you will see horizontal A lines. And then there are sometimes you will see B lines. So B lines are a laser line projections, and they start from pleural line. So this is the pleural line, and from that you will see laser like projections which are going till end of the screen, and they basically indicate presence of lung water or fluid rich subpleural interlobular septa. So basically these B lines indicate presence of fluid and A lines indicate presence of air, but this fluid is within the lung parenchyma. Okay, because it is presence in the fluid rich subpleural interlobular septa. So this is very important to understand. So now again this is showing how these cometal artifacts are formed. So what happens is that this is a pleural line. When the ultrasound beam comes here, a lot of waves are reflected back, telling you that this is a bright structure. Some waves go kind of equidistant, go inside. So these waves go to the probe and they are reflected back. And so that way at equidistant, you will see the horizontal A lines. And they are because of reflection from the bright structure, that is the pleura. And cometal artifacts are because of fluid rich interlobular septa, and that overlapping each other gives kind of cometal artifact. So they are seen like this. This is a single B line. Here there is 1, 2, 3, 4 B lines. And here there are so many B lines that they have become kind of all have formed one uniform structure. So that is confluent B lines. So this is called a single B line. This is called as uh, studies have described this as a lung rockets. So if you are able to see more than 3 B lines in one field, then this is called as lung rockets, which indicates presence of pulmonary edema. And this particular on the right side, when there are more, the A lines are so, B lines are so many that they have become a almost confluent hyperechogenicity, and then that is called as confluent B lines. Now, normal, how is the normal lung ultrasound? In normal lung ultrasound is upper rib, lower rib, bat sign, that is a pleural line, and then equidistant you are seeing A lines. So this is a normal 2D image of the lung. When you put a M mode, what you see is that this particular first half comes as the horizontal lines, and that is called, and then the lung tissue which is moving, breathing, that will give you sandy beach appearance. So this is called as, this is a sand at the shore, and these are the kind of waves in the sea. So sea shore appearance. This is called as sea shore appearance, which is normal appearance. Okay. So this is in M mode ultrasound. So I will show it whenever we are meeting, but so this will be seen like this. So this is the subcutaneous tissue. This is the pleural line. And inside the pleural line, there is a lung parenchyma. This is the lower rib, upper rib. Upper rib is casting shadow. So don't look here. Why this is black? Don't bother, because there is a rib above, and here there is a black. So what we are interested is in this area. So this is called as Merlin space. People have described it as Merlin space. So this area is a Merlin space. They have given the name, so don't worry about the name, but focus on this area. Now when you put a M mode cursor through this like this center and put the button, you will get waves like this. So this is horizontal lines. This is a tissue. Kind of, this is not lung tissue. This is a subcutaneous tissue. And this is a pleural line. And underneath there is a sandy beach appearance. So this is a sand and this is a water basically. So this is clear. This is a normal lung ultrasound. Now once you understand normally looks like this, then you will understand what are the, so basically these are all artifacts. Okay. So, but basically, how do you do lung ultrasound? So, people have done a lot of protocols are there, but traditionally, what you have to understand is that you have to see all the areas of each lung. So, traditionally, they have divided one midline, anterior axillary line, posterior axillary line, and a line joining uh, just below the nipple, horizontal line, and so upper anterior, lower anterior, upper axillary, lower axillary, and similarly on the back side, upper back, lower back. So there are 6 areas on one side, and there are 6 areas on the other side. Also, researchers have described one specific area, this particular area in the fourth segment, this is where the diaphragm, this is the rib cage, and the diaphragm is attached there like this. Now, this particular area is called as PLAP point, P-L-A-P. So, posterolateral uh, posterolateral apical point, basically. So, posterolateral alveolar point, basically. So, here a lot of lung pathologies you will be able to see. Consolidation sometimes happens here early. Fluid collection happens early here. So, the PLAP point is very important to assess. Which probe do you use? Now again, older studies, they have used probe of frequency of 6, 7. Now as a neonatologist, we have mostly one high frequency, one probe which is about 7.5 megahertz. You can do ultrasound with this particular probe, but linear probe of frequency 10 is little better, and it is hold longitudinally orientation with a marker facing cephalad. So this is the probe. This is the orientation marker. The orientation marker should be on the top, as shown here in all the ribs. So all these 4 areas on front, which are going to see, the orientation marker should be cephalad, and it should be perpendicular to the skin surface. So here it will be like this. Here it will be like this. You're not going to do like this. Here oblique is not allowed. So it has to be perpendicular to the skin surface. The orientation marker has to face cephalad, and then you will be able to see the image. So now let's see the pathologies. Okay, what you're going to see. Now pneumothorax. So what happens in pneumothorax is that, just imagine there is a parietal pleura and the visceral pleura is separated with air, because there is air between visceral and parietal pleura. So when you're doing ultrasound from top, so just concentrate here. This is the upper rib, this is the lower rib, this is the Merlin space where we are going to concentrate. So here you're going to see the pleural line, and you're getting all the reverberation artifacts of horizontal pleural line. These are known as A lines. So A line, A line. So what you're going to see here is only A line. You're not seeing a single B line, because presence of B line tells you that the lung parenchyma containing fluid in the interseptal area is in contact with the pleura. But here, because there is a air, it is not in contact. So a single B line rules out pneumothorax. And when you put a M mode cursor through this, what you get, these are all horizontal lines. And this is known as a barcode sign, or also known as C without shore. And this is indicative of pneumothorax. And they say that a negative predictive value for pneumothorax of lung slide or B line is nearly 100%. Now lung slide is basically when parietal pleura, visceral pleura, they slide normally like this. When the baby takes breath, they slide, exhalation. So this sliding movement is seen on ultrasound, and if it is not there, it indicates that there is some separating. So if you're able to see that, it rules out pneumothorax. If you're able to see a B line, it rules out pneumothorax. So what happens in pneumothorax? Pleural line is seen, but then there is no lung slide. A lines are present, B lines are completely absent. If you see B line, it is a it has a negative predictive value of 100%. That if you see a B line, there is no pneumothorax, like that. And parenchyma is not seen. You see C without shore. Now again, just to give you an example, here the baby is breathing. Here there is a rib. Black portion, don't bother. Here there is you have to concentrate on the pleura. So this is the pleural line. Okay. This is the pleural line just below the rib. Okay. This is a pleural line. And underneath you are seeing A lines, horizontal. But when you put M mode, you're seeing all horizontal line. There is no seashore sign. There is what you're seeing is a barcode sign or stratosphere sign, also known as sea without shore. And this is indicative of pneumothorax. So just imagine now this particular child lying supine, there is a air anteriorly, the lung is partially collapsed, and you are assessing laterally. Okay. Now what will happen is that when the baby is taking deep breath, the aerated lung is going to come a little bit up. This particular lung, collapsed lung, is going to move a little bit up and come in contact with the probe here, and is going to give you sign or appearance of a normal lung like this. This portion is normal lung. See shore sign. See shore sign. Okay. And here, see without shore, all the horizontal lines. When the baby is exhaling, the lung is going away from contact of the probe. And this particular point is known as lung point. So don't get confused, but then people have described exactly at what location the pneumothorax is there. And this is known as lung point. So just have a look here. So here when the baby is breathing, the A line is so these are A lines. Yeah, these are B lines coming. Okay. So you'll see something like this, and this is a lung. Basically, this is a lung point. Okay, so it is a very good modality to kind of rule out pneumothorax or diagnose pneumothorax when a baby is on ventilator or any support and baby is having significant respiratory distress. Put it in front, put it on both sides. Look for B lines. If the B lines are not there, then look for lung point. If that is not there, look for lung pulse. There is not there, then you have a pneumothorax basically. So what basically you see is a C without shore appearance and absent of B lines, absent of lung slide, absent of lung point, absent lung pulse. All this tell you that there is no lung in contact with the pleura, parietal pleura, and therefore the baby is having pneumothorax. Well, again, I'll not go in detail of this because it's too much to grasp in the first go. But again, what basically you have to understand is that there are specific signs such as seashore sign, the stratosphere sign or a barcode sign as an indicator of pneumothorax in these babies, and presence of lung slide or B lines rules out pneumothorax. Now coming to pulmonary edema, more the fluid in the lung, more are the B lines. Three or more B lines in one lung field, in one ultrasound field, it is known as lung rocket. And so this is basically indicative of pulmonary edema in the babies. Very often you see this in a baby who has got underlying infection, sepsis, PDA, pneumonia. You'll be able to see this. Then coming to pneumonia, when you do lung ultrasound, the parietal pleura is irregular and there are breaks and thick irregular pleura, and underneath parenchyma will have hyperechogenic lesions like this, and this is known as the Shred sign. So it is indicative of parenchymal lung disease. Also you may be able to see hepatization of lung or tissue like sign, increased vascularity in this tissue, or presence of pleural effusion or thin pneumonic effusion with the underlying hepatized lung. Now this indicates presence of pneumonic effusion. So these signs you will be able to see. So, and this is a particular flap point. Flap point is, this is a diaphragm, this is the chest wall, and this is the lung. So if any fluid collection is there, you will be able to first see at the flap point. Flap point is posterolateral alveolar point where the orientation marker is upward and you're putting it at the posterior axillary line as down as far possible where the diaphragm is joining the chest wall. Now look for the lung movement. So if you see, this is the rib casting shadow. Under the rib there is a pleural line, and under the pleural line there is a lung. Now this lung, if you see, is causing movement with a heartbeat. Now this heartbeat is transmitted through the lung tissue, and you're able to see that this is called a lung pulse. So lung pulse we consider normal in the newborn, but sometimes it is a prominent in case of consolidation. Plus, presence of lung pulse will rule out pneumothorax. If there is a pneumothorax, you are not going to see the lung pulse. Again, it has got a good diagnostic value for presence of pneumonia. So again, I'll highlight this. It is very important. If you ask me what is the good sign to diagnose pneumonia, is it X-ray or ultrasound? Studies have shown that ultrasound is a better modality to diagnose pneumonia. In fact, the sensitivity of both ultrasound and X-ray is same for pneumonia, but specificity of ultrasound is far, far better than X-ray. And I'll explain this point in the next case. Now look at this case, 23 weeker, 45 days old, on high frequency. Any 25 weeker, you know, at this age, generally sick, sepsis, anemia, PDA, 3 failed courses of paracetamol and indomethacin, ibuprofen. Then NEC, which the baby is recovering, baby has a PICC, receiving TPN, and this particular baby on day 45 on high frequency ventilator has a deterioration, and the baby is having high oxygen requirement of around 70%. And you do X-ray, the X-ray shows like this. Now, can anybody tell me what we are dealing? Are we dealing with a pneumonia, pleural effusion, or pulmonary edema? Because the baby is anemic, PDA is also there. So what is it? So basically, the chest X-ray gives you more questions than answer here. So we did a lung ultrasound, and as you can see in the lung ultrasound, there is a pleural line, and below the pleural line you're seeing a lot of B lines, and this is how it is seen, a laser like show from the pleura inside the lung parenchyma type picture you see. And so these are lung rockets suggestive of pulmonary edema morely on that side. Again, there are areas of Shred sign on upper and medial lung fields, and horizontal air bronchograms suggestive of collapse. So basically the baby's MAP was increased, RBC transfusion was given, antibiotics continued the same, and X-ray was repeated after 24 hours, and you will see a clearance. Basically, this baby had areas of consolidation, areas of pulmonary edema, and areas of collapse, and some pulmonary edema. Now, just to highlight that you are more wiser by doing this, there was no pleural effusion. We have not missed out pleural effusion because the X-ray could have suggested presence of pleural effusion. Now again, this second case, diaphragmatic hernia treated, and baby was operated on the third day. And then on day 7, the baby showed gradual increase in oxygen requirement. We did a lung ultrasound, and the lung ultrasound showed arbory pattern hyperechogenic lesions, as you can see here in the right upper lung fields. And basically, this baby had a right upper lung collapse, and this baby was treated, given physiotherapy. So basically, you can diagnose collapse versus consolidation on lung ultrasound. The collapse will be seen as arboriform pattern, static fluid air bronchograms, that there is no air entering in that area basically. And while pneumonia, there is a tissue-like appearance, and there may be some amount of air which is seen going and coming back. As you can see here, these are bright dots which are moving. These are basically air which is going through the hepatized lung. Now coming to the next common problem is neonatal RDS. Now RDS basically diagnosis is clinical and radiological, but now there are certain important questions that when you have a baby with breathing difficulty, are you dealing with RDS, meconium, pneumonia, or any other problem? So how do you see RDS in the newborn? Basically, there is a pleural line which is thickened. There are confluent B lines, as if tissue-like appearance they will give, and disappearance of the A line, which indicates that there is no more air in the lung. The lung is completely kind of collapsed, or hepatized, or not hepatized. The hyaline membrane is formed, or the lung there is no air at all. And you will be able to see lung pulse, and similar appearance in all lung fields is very characteristic of RDS. Sorry. So we had done one study. We had studied 92 neonates, and what we showed is that there is a good clinico-radiological diagnosis versus lung ultrasound diagnosis correlation, and lung ultrasound diagnosis and X-ray diagnosis correlation is also good. And our study showed that modified lung ultrasound score was higher in babies who needed surfactant treatment, suggesting that lung ultrasound can predict severity of lung disease and may predict need for surfactant. Now, around the same time this study was published, and so we had used some different scale for lung aeration. But around this time, this particular study which came out, they have used a different scale, and this is they are screening the lung in three areas: anterior, lateral, and posterior. One, like three areas, and each area they are scoring to the tune of 3. So 0, 1, 2, 3 marks, 0, 1, 2, 3 marks, 0, 1, 2, 3 marks. So on one side 9 marks maximum, and on the other side 9 marks maximum. So there are total 18 marks maximum one can get, and the minimum is 0. So 0 is good. Okay. So if the you are able to see only A lines, no B lines, 0 marks. If you are able to see B lines more than 3 well spaced, then you will call it as you'll give 1 mark. Now if the B lines are coalescent, they are all fused together, then you will give kind of 2 marks. And the coalescent B lines, along with that, if there are any horizontal subpleural hyperechogenic shadows like this, then it is a 3 marks. So one would do lung ultrasound on 3 areas on each lung. If the lung ultrasound score is more than 8, the baby will receive surfactant. If the score is less than or equal to 8, you look for the gestation age and oxygen requirement. If the gestation is low and oxygen requirement is high, you give surfactant. And if the oxygen requirement is less than 30 to 40%, they will not receive surfactant. Now, this particular protocol I have copied from one of the studies, and this is fairly good to practice. Even the European Society on use of surfactant have endorsed use of lung ultrasound to decide need for surfactant. So this is something which is bedside practical and can be done with some practice. And if the lung ultrasound score is more than 8, one can think of giving surfactant. Again, a non-invasive modality. Now, one can also diagnose TTN. So suppose a baby of 35 weeks is there with distress. You want to diagnose whether it is a PDA, sorry, whether it is a TTNB or RDS. So in TTNB, the pleural line is thin, well defined, not not very thick and not irregular. And superior lung fields. So if the baby is lying supine, the upper lung fields they will have more amount of air, and the posterior or lower lung fields will have more amount of water. And as if so, when you're doing ultrasound with a linear probe, when you're putting a linear probe like this, upper lung fields have more water or more air that will give A lines, and the lower lung fields will give confluent B lines, as if there are two different lungs. So this is called as double lung point. There are two different lungs in one image, or under one ultrasound image. The upper lung is something different which is having A lines, and the lower lung is something different which has got a lot of B lines. And this is a stark difference in these two, and therefore it is in these two areas within the same lung field, and therefore it is called a double lung, as if there are two different lungs in one scan, and therefore it is called a double lung point. And this indicates presence of TTNB. Again, just to show you, this is something which we have done. Now this is, as you can see, this is confluent B lines, and here you are able to see A lines. So if I pause the image, here there are A lines, even if it is end, till end you are able to see A lines. See A lines here. So this is double lung point. This is indicative of TTNB. Now next, the pleural effusion. As I said to you, do a flap point assessment, and if there is a presence of hypoechogenic area, it is known as Scott sign, and because it is quadrangular in shape. And if there are debris because of pus, then it is known as plankton sign. It is not seen in X-ray. Again, the advantage of ultrasound is that you can find out whether it is a water fluid or if there is a pus in the pleural space. Again, some people have described as sinusoidal pattern of pleural effusion in M mode. So this is a normal basically. And again, subcostal view, you'll be able to see septi within the abscess. So summarizing, lung ultrasound, basically sliding movement of the visceral pleura and parietal pleura is seen as a lung slide. A lines are horizontal equidistant reverberation lines. B lines is a vertical projection from pleura. Alveolar consolidation is basically tissue-like appearance of the lung, and alveolar and pleural effusion basically is anechoic space above the diaphragm. Septum may be seen. Now these are the signs which are described by Lichtenstein, and they are true. Studies have shown that their sensitivity and specificity is very good, about 90%, some of them to the tune of 100%. There is an international evidence-based statement from international body. And again, Professor Lichtenstein is part of this. And this is also something which is very important for us to go through this. I think his name is there. I'm trying to search, but I think he was a part of this group. So I think this we will stop here. I think so I can speak about point of care ultrasound. Basically, when we are dealing with a baby who is very sick, and such a baby can be undergone assessment of point of care ultrasonography. There are many such protocols existing in adult medicine. For trauma patient, FAST protocol, lung ultrasound in trauma is E-FAST. Cardiac arrest patients, you monitor their heart activity with field protocol. FADE protocol is oral mass casualties. It is for oral cardiac screening in many clinical settings. And CAVID protocol is for mass casualties. Now, something on those lines, we, myself, Dr. Pradeep and Dr. Mohit Sani, we came out with this fast POC USG guidelines, that is focus assessment of sick neonate with point of care ultrasound. And when you have a baby who is very sick or a baby who is otherwise well suddenly collapses, you do sequential assessment of the heart, brain, lung, line complications and abdominal ultrasound to identify these problems. And one will be able to address them and we can avoid the life-threatening situation. So I will skip this and I think this is it. So basically, uh, lung ultrasound can be used to diagnose lung pathologies, and we should be able to incorporate them in our practice. Are there any questions?
Do you really use the lung score for determining? Because somehow my experience has been, it's not so great. I mean, generally the
Yeah,
clinical
I'll tell.
things
See,
that,
I'll be very honest on this. Now, many times what happens, the first dose of lung ultrasound is generally given in odd hours, and many times you are not doing. But generally, while deciding upon second dose of ultrasound, we do take call based on the lung ultrasound, and we find it is fairly useful. But as you said, we are not 100% relying on that. We are looking at baby's distress score. We are looking at baby's oxygen requirement, and based on that, putting it into lung ultrasound picture, then we are taking a call. But yes, I mean, uh, we very rarely have taken call just based on lung ultrasound that a baby whether should receive surfactant or not. I think many of these calls are taken based on clinical distress scoring and need for oxygen and how much is the oxygen requirement.
yeah, many times because in Indian scenario, I think many other times the outbound babies, one that atelectasis has already set in, and mainly there is a mixed picture sometimes because of pneumonia. So somehow, my
Yeah,
experience has not been so great
yeah.
with the ultrasound
We are using it
But
for deciding upon second dose. Yeah, second dose we are
yeah,
using it. Yeah.
but I think at least basic, we must all do is like to rule out a pneumothorax, which is something very easy.
Yes. That we are now able to diagnose. We are confident. Many times, like so many of them, we have diagnosed pneumothorax just based on lung ultrasound, and it is more about practice. And once you diagnose, I think, yeah, I mean, you'll be more confident. Many of you, those who have not kind of used lung ultrasonography for that purpose, it's always a good idea when you have an unexpected deterioration or a very oxygen requirement, very sick baby, to put the probe on the heart, lung, and brain and to see if there are any underlying problems. But yes, I mean, we have diagnosed pneumothorax very often. Pneumonitis also, in our experience, presence of consolidation in the basal segments, posterior segments is very easily picked up by lung ultrasound, and presence and to differentiate whether it is fluid within the lung or pleural effusion, or if there are any septi and this thing we are using. And if we have to drain, then pointing, marking the point by lung ultrasound and doing the procedure, we are doing it. Yeah.
Okay. I think
Head ultra. Yeah.
I think we had enough good discussion, and we look forward to your coming on Sunday morning. And
Yeah.
this is just for information that we'll probably start because we have to get into the main conference. So we'll start
Yeah.
on a Sunday morning at 8 o'clock. Those who may not
Yeah.
be attending 15th, please do come by 8 o'clock so that we have the experience of hands-on whatever. We'll try to make it early before the parents come in so that we do not have an issue that if somebody wants to hold the probe also, so at least that basic can also be taught.
And I think this lecture again will be, I think, shared, and you can again go through that. Even the previous one is shared. So if there are any questions in 1:1, we can solve. And if you want to show like me any particular sign, or if you're finding